Hi there. Welcome to the While You Wait podcast, where it's all about helping women just like you learn about the bladder while you're waiting for your appointment with that specialist. Each week, I'll combine science, medicine, and common sense so you can learn, become empowered, and get started on your journey to dryness. I'm your host, Dr. Sarah Boyles, a board-certified urogynecologist. Let's get started. Hi there. Today I'm going to talk to you about the initial workup and treatment of urinary incontinence. So that basically means what I'm thinking about when I talk to a new patient. So, like all things in medicine, there are guidelines about how you should treat patients with urinary incontinence. And the guidelines that I usually follow either come from the American Urogynecology Society or the International Continence Society. And the initial management that I use is from the book Incontinence, and the 7th edition just came out. So when a patient comes in, the first thing we do is we talk to them about their history. So what kind of things are making you leak? What kind of other symptoms might you have? How is your overall health? I'm trying to figure out why you're leaking. Are you leaking with activity? Are you leaking because you can't quite get to the bathroom on time? Are you leaking for both of those reasons? There are a couple of different things that we always kind of screen for. So, are you someone who has had leakage and it was treated and now it's come back? Is your leakage associated with pain? Do you have blood in your urine? Are you getting a lot of infections? Do you have significant voiding symptoms? Have you had different pelvic treatments like radiation? Have you had a lot of pelvic surgery? Do we think you might have something called a fistula, which is a communication between the bladder and a different organ that shouldn't be there? Are you someone who doesn't empty well? Do you have pelvic organ prolapse? Do you have a mass? These are all reasons why you need to be seen by a specialist. But most of the time, people come in and they have either stress incontinence or urgency incontinence. So we also do a pretty elaborate symptom assessment, having patients do a bladder diary where you keep track of all your bladder symptoms over a 48-hour period. We have you do different questionnaires. We assess how this impacts your quality of life. We frequently do a urinalysis where we're looking for blood in the urine, and we'll do an ultrasound to see how well you're emptying. And then we always do an exam. We're looking for estrogen status, and if you look like you have decreased estrogen in the pelvic area, which might be impacting your symptoms. We check muscle strength to see if you have strong muscles, if you can contract those muscles correctly, or if you have any pain associated with those muscles. And then if you're someone who has stress incontinence, so leaking with coughing and sneezing and exercise, the first line of the treatment is pelvic floor muscle training. If you have overactive bladder, we will do muscle training associated with bladder retraining and lifestyle interventions. That's usually the place that we start, depending on what the patient has done before and what their interests are, what they're most interested in doing. So for stress incontinence, I would tell you that pelvic floor muscle training, so increasing the strength of your pelvic floor, is the first line of treatment. And physical therapy is considered to be the gold standard. There's been the most data generated on pelvic floor strengthening with a physical therapist. Physical therapy will not only individualize a program to your own body and your strengths and weaknesses, but they keep you accountable. They provide a lot of coaching. They provide reinforcement, and they, really make you do the exercises. Some physical therapy places also have virtual group options, so you can do that online, and that can be very helpful. Some women don't have the time to go to physical therapy, and so a virtual class can be very helpful for those women. So most of the time when you do physical therapy, it's one-on-one, but you can also do group classes. And this has really been well studied by Dumoulin's group out of Canada, and they have shown that group classes work if the patient has been taught to Kegel correctly. So if you're someone who knows that you can contract correctly, then doing a group class works really well. And there are things about group classes that people actually like better because there are a lot of positive social things as well. Online classes can work too if you know that you contract correctly. And, there are a lot of things that I don't particularly like about the pandemic and how lives changed in 2020. But I think that there are a lot of amazing online resources that developed at that point in time. So some of the resources that I use for my patients, I'll direct patients to the Vagina Coach, Mama Made Strong, or the Vagina Rehab Doctor, because I think that they all three have very good online courses and education that can really help with pelvic floor strengthening. And so for some women, that's a better fit. But again, you have to know that you can Kegel correctly. There's also some concierge physical therapy out there, and a concierge physical therapist is someone who will come to your house. The difference between a concierge and home health is that you have to qualify for home health, and not everybody qualifies for home health. A concierge PT, sometimes they take insurance, sometimes it's out of pocket, but that might benefit you if you're someone who, say, has a new baby and it's hard for you to get out of the house, or maybe you have a new baby and a toddler. That can really facilitate pelvic floor strengthening. So you can also do Kegels on your own. I think that there's, some debate out there online about whether Kegels work, but they definitely do work. There's a lot of data out there that shows that they work. But for them to work, the exercises have to get progressively harder over time, just like any other exercise routine. So usually if we have patients doing Kegels, we'll have you start doing them flat, then have you do them sitting and then standing. That's using gravity to make it more difficult. We'll have you increase the number of contractions and also increase the length of hold time. So how long you're holding that pelvic floor contraction. So Kegels definitely do work, but they also require the most kind of personal dedication, right? You have to be your own coach. You have to be your own motivator. And that's something that can be hard for a lot of us. The other thing that I would say about pelvic floor strengthening is that for most women, you don't see a great benefit for about 6 weeks. And so it's really important to stick at it. And it's hard to do things for that length of time if you're not seeing a benefit. So the minimum amount of time I would say is 6 weeks, and usually it's 6 to 12 weeks. If you can do a Kegel contraction correctly, you could use a peri-trainer to strengthen your pelvic floor. And there are lots of peri-trainers that are out there. Peri-trainer is a device that fits in the vagina and it measures the pressure. So it theoretically measures how strong your contraction is. And that can help with motivation. There are ones that are associated with games, so it can be more interactive and interesting. They track your progress, which can be super helpful. And so that's something that might help keep you motivated and might be a little bit easier for you. There is one pelvic floor trainer on the market called the Leva. And the Leva is different from other pelvic floor trainers in that it actually measures muscle movement. It offers coaching. It does give feedback back to your physician, but it requires a prescription. Because it measures movement, it can tell you if you do a Kegel correctly, which is different than other pelvic floor trainers. When a pelvic floor trainer measures pressure, it can't actually tell you if you're doing a contraction or you're bearing down. So you really have to know that you are doing a contraction correctly. There are also devices out there on the market that contract the pelvic floor for you. And two examples of that are the Emsella chair. So the Emsella chair uses a magnetic wave to contract your pelvic floor, and the Anovo shorts, which uses an electrical stimulation to contract the pelvic floor. So these devices will absolutely strengthen your pelvic floor, but it's not clear how long the effect will last. They're often quite expensive and often out of pocket. And if you have pain, I would not suggest doing either one of these devices. It can increase the pain, and so it's just not a great option at that point in time. But there are women who have gotten benefit from these different interventions. If pelvic floor strengthening does not improve the leakage or remove the leakage, then the next thing that we look at is a pessary. And a pessary is an insert that fits into the vagina. It puts a little bit of pressure on the urethra and it stops leaking. About 40% of women are cured with a traditional incontinence pessary, and that increases to about 53% if behavioral therapy is added. There are over-the-counter pessaries for incontinence, so the Impressa, Revive are over-the-counter. Uresta requires a prescription, but there's no fitting appointment, which is different than our traditional pessaries that we give to people in the office. And the Uresta is working on becoming over-the-counter, and hopefully that will be available a little bit later this year in 2024. The Uresta has better data than a lot of the other incontinence pessaries, and it looks like it does work better than our traditional incontinence pessaries. There's also something called a urethral seal, and that's just a little seal that you can put on the opening of the urethra to stop leaking. It only works for small amounts of leaking. You have to remove this seal in order to empty your bladder. But for the right woman in the right situation, that can be a very helpful ancillary device. So if those things don't adequately treat stress incontinence, there are a couple of other things that we can do in the office or in the operating room. And the first is urethral bulking. Bulking is something that I think of like filler. It plumps up the tissue. It makes it less likely to leak with exercise and with coughing. It improves leaking in about 50 to 70% of women. There are lots of different materials that you can use, and no one is clearly better. Sometimes we do have to re-inject the area. And I would tell you that I think of bulking as something that improves leakage, but doesn't necessarily cure it. I think this is a great treatment because there is no downtime. And so if somebody really understands what they're going to get and that it's not a perfect treatment, but they don't have time for a surgery, or they're not interested in a surgery, or maybe they're interested in having more children, this is really a great option. And then the last and most aggressive thing is surgery. Surgeries are the gold standard. So surgeries, I would tell you that mesh slings are the gold standard right now with about an 85% cure. Surgery can absolutely be done without a mesh. And there are lots of different surgical approaches that can be discussed with patients. The surgeries have become less and less invasive over time. And if someone is bothered by their leakage, moving on to surgery is absolutely reasonable if more conservative things have not worked. There's also some research that's being done right now with stem cell therapy. There is an ongoing phase 3 clinical trial that I'm really excited about, where you use your own stem cells from a muscle biopsy, and then they're treated and re-injected into the urethra. And I'm very excited about this data and what this might mean for treatment in the very near future. And then there's a lot of data right now about, or I guess not data, but noise about laser and radio frequency treatments for stress urinary incontinence. These devices are heavily marketed. And I would tell you that the most recent data has shown that CO2 lasers are equivalent to sham, as is radio frequency, meaning that there's really no benefit there. There's some thought that a YAG laser may help with mild leaking, but that research is ongoing right now. And so right now I would tell you that I really do not think there is enough data to recommend laser or radio frequency for stress urinary incontinence outside of a research trial. So those are the treatments for stress incontinence. For urgency urinary incontinence, I would tell you that we also start with pelvic floor muscle training, and all of the options that I discussed earlier for pelvic floor muscle training are still an option here. We also do some behavioral training. The first thing that we do is we talk to you about your diet and behavioral modifications that you can do. There are a lot of triggers for overactive bladder, so it's important to manage fluid, to reduce nighttime fluids so that you're not getting up frequently at night. Reduce overall fluid intake if it is excessive. You want to get rid of bladder irritants. And so I think the common bladder irritants that people think about are things like caffeine and alcohol, but I would tell you that carbonated beverages are also really common. One of the things that I see frequently right now is carbonated water causing a lot of bladder irritation, especially the flavored carbonated water. This is something that so many of us think is healthy, but can actually be a bladder irritant. So, taking the time to journal what you're drinking, journal what you're eating, looking at when you have the symptoms can be hugely beneficial. Sometimes things that you could tolerate eating and drinking when you're younger, as you get a little bit older, your body just doesn't like them anymore. And that can be a little bit of a rude awakening and can take a little bit of investigation to figure that out. We also have you do timed or scheduled voiding. So you're going to the bathroom based on the clock and not when you feel that urge. That can lengthen the time between voids and get rid of the frequency, and that can help dramatically. Weight loss can help with urinary incontinence, and so that's a very important thing to discuss. And as we all know, is good for your overall health, although never an easy thing. And then managing constipation. Constipation can increase bladder leaking, and so that is always an important thing. We also teach women to do urge suppression, and urge suppression uses your own body reflexes to calm the bladder down and get rid of that super urgent sensation. And so the way that we teach women to do this is to do 5 quick pelvic floor contractions, distract yourself, deep breathe and relax, and wait for the contraction to pass, and then walk to the bathroom. So when you do those quick contractions, it contracts your urethral sphincter in your pelvic floor, and it tells your bladder to stop contracting, which creates that urgency sensation. And the deep breathing and relaxing also generates the right vagal reflexes to calm your system down and increase your parasympathetic system. It's a really easy thing to discuss, but a hard thing to do. But this urge suppression will absolutely help with overactive bladder symptoms. If behavioral modification and pelvic floor muscle training doesn't work, then we move on to medications. There are about 8 medications on the market right now, and they have different side effects. And it's important to look at your overall health history and your medications that you're currently taking before we decide which one is the best for you. In general, I would say 50 to 80% of women are improved with medications, but some of the medications have a lot of side effects, and so discontinuation rates are high with medications. There are also some supplements that can help with overactive bladder, and the one that I talk to patients the most about is pumpkin seed oil, which is available over the counter as azo bladder control. There aren't a lot of side effects with this, and it can be very helpful for overactive bladder. If medications don't work, then you can move on to third-line therapy, and the third-line therapies include Botox and nerve stimulations. So with Botox, when I inject Botox, it's always important to know if a patient is getting Botox in other parts of the body, because we definitely don't want to give too much Botox. Botox is usually injected in the office. We numb people up with a little bit of lidocaine, and that usually works pretty well. It is 65% effective for somewhere between 6 to 12 months. If Botox works, it always needs to be repeated because it will wear off over time. About 8% of women will have trouble emptying their bladder after Botox, and about 2% of women will need to catheterize themselves. And so that's always a really important discussion before Botox. And there is an increased risk of urinary tract infections with Botox. There are also different nerves that you can stimulate to help with overactive bladder. So you can do a sacral nerve stimulation, which is a nerve that runs along the back. And that's a permanent implant that we think of like a pacemaker for the bladder. Your tibial nerve runs along the middle side of your ankle, and you can stimulate the tibial nerve as well, and that will calm down the bladder. There are different ways to stimulate the tibial nerve. You can do it with the TENS unit and do it at home. We can do it in the office with a small needle that is similar to an acupuncture needle where you stimulate the nerve with a little bit of electricity. There is also a new implant that you can do that will stimulate that nerve. Sacral nerve stimulation, about 60 to 90% report improvement. 30 to 50% of women report cure. There's about a 3% rate of the device needing to be removed or revised, but this can offer a lot of help for women. And then stimulating the tibial nerve, it depends on how you do it. The TENS unit at home has the lowest rate of cure, which is about 50%. Doing it in the office with a needle is about a 60% improvement rate. And then the implant currently reports about an 80% improvement rate. I think the important thing for women to know is that there are a lot of different treatments out there. Sometimes we just try different treatments before we find the one that fits you. But I also think it's just so important to realize that there is a lot of hope out there. There are different things that you can try. There are always different things that are coming to the market. There is more and more research that is being done. And so I'm super optimistic about the treatments that we have and the new treatments that are being generated all the time.
Thanks for listening. If you want more information about me or my online work, check out my website at www.thewomensbladderdoctor.com.